Swadika, and good afternoon, everyone. I'm Rasmon Kalayasiri from Department of Psychiatry, Faculty of Medicine, Chulalongkorn University. I'm the director of the Center for Addiction Studies, supported by Thai Health Promotion Foundation. Today, it is my great pleasure to give a talk at the 24th Bangkok International Symposium on HIV medicine. The topic of my talk today is harm reduction strategies for persons who use amphetamine type stimulants or ATS. First, I would like to talk about addiction in general. For the substance like amphetamine, it could affect the brain reward system that comprise of ventral tegmental area, amygdala, hippocampus, nucleus accumbens, and the prefrontal cortex or PFC. At the VTA, dopamine, which is the main neurotransmitter for reward, is synthesized and is sent to various locations in the brain reward system. For example, at the prefrontal cortex that is responsible for the attention of the substrate of the substance, and nucleus accumbens that decide what to do, such as to take or not to take the substance, or in this case, a piece of cake. And the amygdala is the location for the memory about mood, for example, like pleasure. And hippocampus, which is responsible for memory about the environment at the time of a person who take drugs. Amphetamine affects this pathway that result into addiction. In natural reward, like a piece of cake or food, if something bad happened when we eat a piece of cake, it would obstruct us to take it more. But for the addictive substance like amphetamine, when something bad happened, for example, someone get sick after taking the substance, the property of the drug could not prevent the person to discontinue the substance. As a result, the person still takes amphetamine more and more, even something bad happened. And this is the concept of addiction, which is the chronic relapsing brain disease that characterized by compulsive substance seeking and use despite harmful consequences. And harmful consequences happen both in the legal substance or illegal substance, and sometimes alcohol, for example, is a legal substance but can cause more harmful consequences than illegal substances. For amphetamine, amphetamine derived from beta phenylethylamine, and it is added with a methyl group to be amphetamine, which has a property similar with monoamines that could cause memory disease. Amphetamine has a main mechanism of action by promoting dopamine release from the vesicle and release to the synapse that can cause neurotoxicity. If the amphetamine is added again with a methyl group, it becomes methamphetamine, which is more or higher potency than amphetamine. And methamphetamine has been used widely as a drug of abuse. Mostly people who use it often use by snorting or smoking, but some persons use methamphetamine by injection, which could be a risk factor for HIV infection if they share the equipment to other people. At the first use, person who use it may have the intoxication effect, like anxiety, but for long-term use, it can produce dependence to amphetamine, which has a withdrawal and tolerance effect, which leads to phenomenon are the main symptoms of dependence to drug of abuse. And for methamphetamine withdrawal symptoms, it could produce craving, anxiety, nightmare, or loss of interest, when stop using the substance and we call it withdrawal symptoms. The person would try to take methamphetamine again and again to relieve these withdrawal symptoms. And one concern about methamphetamine is the co-occurring disorder or comorbidity, and sometimes we call it dual diagnosis. This is the co-occurring between psychiatric disorder and the substance use disorder. For example, like psychotic episode can be induced by methamphetamine use, and somehow the symptoms of psychotic from primary psychotic disorder like schizophrenia and psychotic symptoms from methamphetamine-induced psychosis are very similar, and it is difficult to differentiate between the two disorders. The prevalence of substance use is high among psychiatric patients. At the same time, prevalence of psychotic illness is high among persons who use substances as well. And for example, 1/3 of chronically ill patients use substance during 6 months before the evaluation. And many reports in Thailand show the same trend of the high prevalence of substance use in psychiatric patients. For example, at the Psychiatry hospital, the lifetime and the 3 months prevalence of any substance use were very high among psychiatric outpatient patients. At Chula, we also saw a very high percentage for about 1/3 of persons who get the service at the psychiatric clinic. 1/3 of them have a lifetime substance use, including nicotine, alcohol, methamphetamine, cannabis, cocaine, and prenups. This is the result from Somdet Chao Phraya Institute of Psychiatry. And you can see here that prevalence rate of smoking behavior were 70% in your group. Is a person who has a schizophrenia. And this is the result from Civilian Hospital. The prevalence of nicotine dependence in psychiatric patients is high as well. At Civilian, the prevalence is about 16.9%. So this is there are many reports about this, that the co-occurring between the substance use and psychiatric disorders. And the hypothesis of the high prevalence of addiction among psychiatric patients is first is about the self-medication. People use substance to treat their symptoms of anxiety, depression, or even the side effect from psychiatric medication. And the second hypothesis is the substance that had induced the psychiatric disorder, or is the cause, the substance is the cause of the psychiatric disorder, such as what we saw a lot about methamphetamine that can induce psychosis. And the third hypothesis about the comorbidity is the common factors between substance use disorder and psychiatric disorder. And previous studies found that methamphetamine use is associated with a higher rates of sleep problems, paranoia, depression, anxiety, irritability. And this is a higher rate than cocaine use. Cocaine is another psychostimulant, but it has a shorter half-life than methamphetamine. And you can see here from this picture that for hallucination, person who use methamphetamine has higher rate of hallucination than cocaine, and also severe depression, that these persons who use methamphetamine have higher rate of severe depression than cocaine. And the experience symptoms after first use of methamphetamine includes anxiety symptoms like panic, mood symptoms like mania, and psychotic symptoms like paranoia or hallucination. In Thailand, there is a study that shows that the psychosis symptoms from methamphetamine last for about one third at the 7 years follow-up. I mean, at the 7 years follow-up, about one third of the person who has methamphetamine psychosis still has psychosis at the 7 years follow-up. And our study also shows that about one fifth of individuals who use methamphetamine has paranoia from methamphetamine has the persistence of symptoms even after the intoxication effects has increased. For example, of the 289 individuals with methamphetamine-induced paranoia, the paranoia duration was usually, most of them say that usually lasts for like 3 to 4 hours. And but one fifth of them saying that it lasts more than 1 day. And some of them say it lasts about 2 weeks after using methamphetamine. And here is the example of persons who had paranoia from methamphetamine use. For example, when the average age of onset from methamphetamine use was around age 17, the onset of paranoia was about at age 20. So the latency to paranoia onset is about 3 years after first use of methamphetamine. However, about 8% said that they had paranoia since the start of methamphetamine use, and another 8% said they had subsequent episode of paranoia without methamphetamine use, and 17% had paranoia beyond the intoxication effect. Then about 11% had only one single episode of paranoia in their lifetime. And we also found that paranoia occurred more rapidly over the course of methamphetamine use. This is a latency to methamphetamine-induced paranoia within a binge. But you can see here that the latency to paranoia within a binge decreased over the course of methamphetamine use. In our study, we also studied the genetic risk of the psychostimulant. We studied the candidate gene called dopamine beta hydroxylase, which can turn dopamine into norepinephrine. And in our previous study, we found that the association between the T allele of the person who used cocaine. The person who has T allele has low activity of dopamine dihydrogenase, and this person has a higher paranoia when administration of the cocaine. And when we studied this in Thailand for methamphetamine, we found that the T allele predicts lower odds of methamphetamine-induced paranoia. And it is the T allele also associated with cigarette smoking and alcohol dependence. Anyway, besides of the genetic factor, this is very important because other environmental and other psychiatric disorders may predict the occurrence of paranoia from methamphetamine. For example, severity of methamphetamine use, severity of methamphetamine dependence, younger age of onset of methamphetamine use, and other personality like antisocial personality disorder, suicide, pathological gambling, and other substance use disorder. This is the factors associated with the occurrence of methamphetamine-induced psychosis. How about the treatment? We can call this is a harm reduction strategy, since it could reduce the symptoms accompanying methamphetamine use, such as the treatment can reduce withdrawal symptoms of craving and can reduce psychosis that was produced by methamphetamine. But for the treatment, specific treatment for the methamphetamine, right now, currently, there is no approved medication for the treatment of methamphetamine use disorder. So we need to reduce these symptoms specifically, but no specific medication for the treatment of the substance use by itself. We just can reduce the withdrawal symptoms by using some medication, and we use psychosocial treatment. It's like a major focus for the treatment for methamphetamine use disorder. And there's some study medication for the treatment. For example, SSRI, which is an antidepressant, may be used for comorbid with major depressive disorder, but they need to monitor craving response. Mirtazapine is another antidepressant, which some study saying about the reduction of the craving for methamphetamine. Bupropion may be effective in persons who use methamphetamine in low amount of methamphetamine. Methylphenidate maybe have some effect to treat persons with methamphetamine injection. This is just some reports, but no consistency, and no medication were approved for the treatment of methamphetamine use disorder, but this is just some clinical trial that I first studied. And for the psychotic symptoms, antipsychotics for methamphetamine induced psychosis can be used, and usually we prefer using the typical antipsychotic because we do not want to reduce dopaminergic activity. So a typical antipsychotic may be favorable than typical antipsychotic, since typical antipsychotic have a hypodopaminergic effect than the typical antipsychotic. And this is the studies from Thailand. For example, we study the quetiapine, found that it can reduce psychotic symptoms, just like other primary psychotic disorder. Here is the study that we did a long time ago. Which is typical antipsychotic can reduce psychosis from methamphetamine, and the effect is comparable to the typical antipsychotic like haloperidol. And there are many other investigative agents that has been studied to treat methamphetamine use disorder. For example, the serotonin agonist or serotonin antagonist. Some the dopamine autoreceptor. So there are many other many chemicals that can these are under investigation for the treatment of methamphetamine use disorder. But for other harm reduction, besides of the medication for the treatment of psychosis, for example, other harm reduction strategies for methamphetamine use include the avoidance of using methamphetamine if someone has high risk of paranoia that could be induced by methamphetamine. For example, the person with antisocial personality which we found that is highly associated with methamphetamine-induced psychosis. People who has a younger age of onset of methamphetamine use. So we need to avoid using methamphetamine at young age. And you can see from the previous slide that the onset of psychosis from methamphetamine may be at age 20s. After that, using people who have suicidal risk, have suicidal ideation, usually have a suicidal attempt, need to be very careful when using methamphetamine. And people who have some other substance use disorders such as nicotine or smoking and alcohol dependence need to avoid using methamphetamine. And if someone need to use methamphetamine, need to avoid high dosage of methamphetamine since it has a dose relationship between paranoia and high dosage of, and avoid frequent methamphetamine uses. We need to use, if someone need to use methamphetamine, use it just not too frequent. And of course, avoid injection because injection is a risk factor for other infection like HIV. And if need to use by injection route, need to use clean sterile equipment, and need to someone use methamphetamine injection for the chemical sex. So need to have the safer chemical sex, use condom for example, and to have other measure for to prevent HIV. And another thing is about being knowledgeable about the product, because we do not know something may be added inside of the substance that someone is using. So we need to notice the substance. So in conclusions, methamphetamine is a highly addictive substance, and methamphetamine has a high comorbidity with psychiatric disorders, including the psychotic disorders. And harm reduction from methamphetamine use include both biological and non-biological. The biological is the medication to treat the psychiatric symptoms, and to for the non-biological harm reduction is to avoid risk factors that can induce methamphetamine-induced psychosis. So I would like to thank all my collaborators, and that includes all my presentation. Thank you very much.